talk about revolutionizing wet AMD care, explore emerging therapies, and game-changing clinical insights. The agenda of what we're going to talk about is challenges of current treatments and potential of tyrosine kinase inhibitors, or TKIs. We're going to talk about the use of TKIs in wet AMD. We're going to have a panel discussion with my good friend Carl Danzig, and we're going to figure out how will these TKIs fit into the current therapeutic landscape, and then we'll have some time for question and answer. As I mentioned, I'm very excited to be joined by my dear friend Carl Danzig from the Rand Eye Institute in Deerfield, Florida, Deerfield Beach, and I'm Michael Singer from San Antonio, Texas. These are our financial disclosures. So what we're going to do is we're going to discuss the current unmet need of patients with neovascular AMD. We're going to describe the newer therapies on the market, and then hopefully appreciate the clinical trials that really demonstrate durability and potential efficacy. This could not have happened without a grant from the Clinical and Patient Educator Association and IVISTA Medical Education, and the activities being supported by an independent medical education grant from iPoint Pharmaceuticals. To claim credit at the end of the program, we'll send an email to you with instructions on how to claim your CME credit and print your certificate. If you have got questions, there's a question box below, and send your questions and comments, and we'll try to answer them at the end of the presentation. Without further ado, I'm going to introduce Carl to talk about the first section of our presentations this evening. Take it away, Carl.
Thank you, Michael, for that wonderful introduction. Thank you, everyone who is joining us tonight. I'm very excited to participate in this CME event. So let's go back in time a little bit, and let's talk about what's been approved for the treatment of wet AMD. And traditionally, it's been focused on intravitreal anti-VEGF injections. Before that, we had different types of laser, we had photodynamic therapy, but really over the last 2 decades, maybe slightly less, we've been doing injections. And the current monotherapies are approved for a range anywhere of Q4 to Q12, even up to Q16 weeks. But what we see in clinical trials, and it's presented on the podium all the time, is not the same as what we see in clinic. And we know that there's undertreatment in real-world settings, and this may result in suboptimal visual gains when it comes to neovascular AMD. And we just see fewer injections in patients in real-world trials. So we know that visual outcomes in clinical trials and real-world studies may be tied to the number of intravitreal anti-VEGF injections received per year. And we see this in wet AMD. We also see it in DME. But what we also know is that the majority of patients with wet AMD are likely undertreated during the first year of management. And we see that here, that 73% approximately are receiving 5 or less injections in the first year. Here, we have a retrospective study of US medical records from 2012 to 2016, and the real-world data show a relationship between visual outcomes for patients with wet AMD and the number of anti-VEGF monotherapy injections they receive. We have, with the blue bars, the number of eyes receiving injections over the course of the year, and to the burnt orange circles correlates to vision, and we see a direct correlation. And we can see that again when we look at this slide, that patients who receive more injections have better vision. They have more visual gain. But why do people not receive the right amount of treatment? We see the clinical trial results and we see the real world results, and they just don't align. Well, there's a burden for the doctor, for the patient, the caregiver. The patient comes in, but maybe someone's to come with them. Then the patient may have to come in monthly, every other month. If they're really lucky, they can come in every 3 to 4 months. Not always true. But how do they get there? Some of these patients have low vision. They can't drive. Maybe they have other medical conditions impeding their visits to us. There's also the financial burden. We're seeing that currently with lack of copay assistance. There's also a dissatisfaction of visual outcomes. Patients say, hey, I used to see so well, and now even with the treatments, I'm just not able to see like I used to. And I know you're telling me, doc, it's getting better, but I don't feel it's better. And then that goes into that limited response. So how do we address adherence to prevent that visual loss, to prevent that loss to follow-up and hence visual loss? So we counsel patients before starting therapy. I talk to my patients. I say, we're going to do a number of injections monthly, and then we're going to spread them out. And all they hear is, I'm doing 3 injections for the rest of my life. And it doesn't quite work that way, as we all know. But then we also have to think about, well, how do we follow up with patients who miss appointments? We have our office send letters, we can send an email, we can send a text. Some of our patients don't participate in modern technology. Many do, but some just don't. And then how do we get to them? And then we have to also increase the efficiency. The more patients we have, it's harder and harder to fit all these patients into our trial. So the visits can get kind of long. And then we also have to then maximize time for patient education. I know in my setting, I will be more than happy to talk to a patient, educate them as much as I can, but having to keep repeating that education on a monthly basis really slows down the clinic. So we know that when we look at the IRIS registry about the impact of anti-VEGF treatment, and we looked at the patient characteristics and visual outcomes in wet AMD, and this was a great article by Dr. Wyckoff and team. And what they showed here is that in patients that were lost to follow-up, so the longer the total follow-up correlated with worse vision down the line. So they may have had better baseline vision and worse vision later. So what we see here is at baseline, everyone improves, but at year 1, then 2, 3, 4, 5, and 6, they taper down and they lose that visual gain that they initially had at year 1. And we see that here with a bar graph. Furthermore, we also know that nearly 40% of patients discontinued treatment in less than 2 years. And this was presented at ASRS in 2022 by Dr. Lang. And we see that the treatment discontinuation was observed in 38.8% of patients. That's over 62,000 eyes. And it occurred at around 1.7 years, 89 weeks after starting treatment. So that's less than 2 years. 40% of people just don't get treatment anymore. Now let's look at treatment switching. So any type of switch between anti-VEGF agents, about 33%. Now, honestly, in my clinic, it's probably a little higher than that. But in this study of an enormous amount of eyes, 33%. But then we start switching from bevacizumab to an on-label agent, about 21%. Few patients switch back, but we looked at the duration before that first switch. And in weeks, 81 weeks, 74 weeks. So that might be a little long for some of us. In my patients, we generally try to switch a little faster. But in the end, a lot of patients are switching. Well, why? For all those reasons that we talked about. So Dr. Singh presented at Macular Society in 2022 about the IRIS registry. And this is an interesting study that was done that looked at eyes in the IRIS registry that had wet AMD and they were treatment naive with better than 2400 vision at onset. If they had DME or RVO or DR, they were excluded. And then they looked at patients that were actively treated and eyes that were not actively treated. So now let's look at the actively treated eyes. Received anti-VEGF within 3 months of diagnosis. And the question was, did they receive sufficient treatment, 7 or more injections in year 1, or insufficient treatment, less than 7, so 6 or less in year 1? And there was a boatload of patients here, almost 110,000 in the sufficient treatment arm and 74,500 in the insufficient treatment arm. And what we see here is a correlation between injections, and then we're going to look at vision in a second here. So the number of injections, almost 9 in the sufficient treatment arm, and the duration between injections, 44 days versus 78 days in the insufficient arm. But then we start looking at mean BCVA change from baseline at year 1, and it's almost a full line in the sufficient treatment arm. But in those patients that received 6 or fewer injections in year 1, they essentially did not have any vision gain. They just kind of stayed the same. This has been deemed meaningful and significant. So at this point, we're going to start talking about the promising results from the tyrosine kinase inhibitors. Now let's talk about them a little bit because it's a different mechanism of action. We know that anti-VEGFs act on the extracellular side by binding selective ligands. VEGF-A, B, Ang-2. We see that here with aflibercept, faricimab, ranibizumab, bevacizumab, and brolucizumab. And they bind to these selective ligands like VEGF-A to prevent receptor binding and pro-angiogenic activity. Tyrosine kinase inhibitors act differently. Where the anti-VEGF act on the extracellular space, these act on the intracellular space. And what does this do? It lets you target all of these different receptors inside the cell. So they bind the intracellular tyrosine kinase domains of VEGF receptors, inhibiting ATP binding and preventing activation of pro-angiogenic signaling across all of these receptors. So it's a pan-VEGF inhibitor. And we see that here in an article by Dr. Das that elucidates this and talks about this a little further. And then we start looking about these different platforms for different drugs here. And we have different molecules and vehicles. So there's the hydrogel, there's a suspension, and there's the polyvinyl alcohol. And that's done in different trials here. So axitinib with Ocular Therapeutics hydrogel. This is suprachoroidal injection with axitinib, with Clearside, and vorolanib in the iPoint trials. And what we see here is that they all have a redosing interval of about 6 to 12 months. And this can be a game changer for our patients if we're going to have a therapy last 6 to 12 months. And that changes the equation for so many of our patients. Those patients who are lost to follow-up, those patients who are unhappy with the efficiency of our practices, unhappy with, burdening their family. What we do see here is the vehicle persistence is a little different between the different molecules. And obviously the suprachoroidal suspension is gone fastest. And what we also know about TKIs, they inhibit angiogenesis more effectively than bevacizumab in vivo. And with pan-VEGF receptor inhibition and suppression of multiple pro-angiogenic signaling pathways, that may be more effective than targeting and inhibiting a limited number of VEGF ligands. And we see that here. IC50, its inhibitory concentration of 50, is a measure of a drug's ability to inhibit receptor activity by half. So dosing below that may result in suboptimal efficacy, and above that provides little to no additional therapeutic benefit. So there's a little sweet spot there. So what we see here is that all of these TKI inhibitors are potent pan-VEGF receptor inhibitors. Only axitinib inhibited Tie2, but is this truly relevant in human tissues at clinically relevant doses? And all of them meet the necessary potency in their respective clinical formulations as is. So at this point, I'd like to hand it over to Michael to talk about a little bit more about the tyrosine kinase inhibitors.
Oh, you did a great job and really set the stage for what we're going to talk about. Understanding the fact that the treatment burden is very high for our patients, that new medicines have to be approved so we can increase the duration between medicines to hopefully increase compliance. And you did a really good job of going over the basic biology of what a TKI is and where it works. So, as Carl talked about, TKIs are intracellular as opposed to anti-VEGFs, which are extracellular. And there are 4 TKIs that have been used in ophthalmology in clinical trials. We're going to focus tonight on the OTX TKI axitinib, the EYP-1901 vorolanib, and the CLAS AX axitinib suprachoroidal suspension. They all have phase 2-3 trials underway. They all have biologic activities like anti-VEGF, but they work intracellularly. They have good safety, and the durability has been at least 6 months or more. And, they're either put in the eye through an intravitreal injection or in the suprachoroidal space. And we'll go into a little deeper in a moment. So the first one we'll talk about is the axitinib by Ocular Therapeutics. This is an intravitreal injection through a 25-gauge needle. It is a hydrocell implant that's incorporated, that's given over time. It basically, water activates it, and what it does, it activates the medicine to to potentiate an anti-VEGF type reaction. It's a small fiber. It dissolves over time. Interesting to note that it actually dissolves even earlier than all the medicine is used up. So, and we'll show that in the clinical data going forward. So the original phase 1 trial was a multi-center randomized trial looking at people with previously treated wet AMD who actually could have their fluid controlled, and it was randomized 3-to-1 based on different doses of the OTX-TKI versus aflibercept. At day 0, patients were given the OTX-TKI, and at month 1, both were given aflibercept to start. And then the OTX arm was followed over time to see when they needed to get rescued. And they were rescued based on criteria of loss of 10 letters from previous BCVA with current BCVA worse than baseline, 75 microns increase from best value, and 5-letter loss. So you had to have swelling and letter loss or new macular hemorrhage. And essentially, they had a 7-month and 10-month analysis, and actually a 12 months, which we'll go over. What's interesting to note is regardless of which dose of axitinib used, it seemed to do a really good job in stabilizing vision and stabilizing OCT relative to aflibercept given every other month. And when we look at rescue-free in terms of rescue injection, by week 28, 73% of people did not need rescue injection, and that held to month 40. And it's interesting, again, the implant was gone by 8 or 9 months, but it seemed to maintain the anti-VEGF effect up to week 40, and then it still stayed relatively stable till week 52 where it dropped off. Looking at this another way, if you look and see, these are really high need people. These were people that needed pretty much almost monthly injections for the most part. And there was an 89% reduction in the treatment interval using treatment burden with increasing treatment intervals for most of the people, if not all, by using this TKI. Obviously, we worry about safety. Safety, these things are really pretty safe. There was one case of endophthalmitis, which was moderate and resolved, and one was worsening of cataract. But overall, they seemed really safe, and they seemed to do a pretty good job. And there were no severe ocular adverse events in either arm or serious adverse events for that process as well. As a result of that, they're underway with these phase 3 trials. They have 2 phase 3 trials going on, and they're totally designed differently based on FDA guidance. The SOL-1 trial is a superiority trial. For those of you who are not familiar with superiority trials, they really have to be able to show superiority versus sham of 15 letters. And the way it's done is patients who are treatment naive essentially are going in and they have a diagnosis and are given 2 aflibercept to start with to see if they can get their vision better. Is there visual potential? Can you gain 10 letters by day 1, or can you get to 20/20? And then what you're doing is you're being dosed either with OTX-TKI or aflibercept at baseline, and then you're being watched to see when you lose 15 letters. If you lose 15 letters, then essentially you get rescued and you essentially leave the active arm of the study. This has a 36-week primary endpoint and a 52-week and 104 safety endpoint. The second study is SOLAR, which is similar to what you're mostly used to, which is a non-inferiority trial. They're looking at a similar patient population. They give them 3 aflibercept shots at the start. They wait a month, and they want to see if there is, will they get dry? And then they're randomized to one of 3 arms. They're aflibercept 2 milligram on label every other month, OTX-TKI every 6 months. So this is the redosing trial, because up to this point, they haven't been redosed, or aflibercept 8 milligrams every 6 months, and the primary endpoint's at week 48. So what we're trying to figure out is how does it do based on what we standardly treat in the clinic, and what happens when we redose the medication. I'm going to switch gears and talk about a different medicine, EYP-1901 or vorolanib, which essentially is a pan-VEGF inhibitor. It's been used in the past as an oral agent. However, it had some liver toxicity. Even though it had a signal, they had to stop the study. It's either 1 or 2 implants that are given, again, intravitreal injection, 25-gauge needle. What is interesting from this medicine gets started immediately. The OTX medicine has to build its way up a little bit, but this medicine starts from the get-go. And it turns out that the medicine is depleted before the implant, which is absorbable, is resorbed. These are studies that show that there is good penetration in all layers of the eye with this medicine over time. And there was a dose escalation study, the phase 1 DAVIO trial, which is Duracert and vorolanib in ophthalmology. The primary endpoint was safety, but secondary endpoints of what we care about is what's the mean time to supplement, change in BCVA and CST. They literally had 4 different doses that they were treated over time. It was a 1-year trial. What's important to know, this is a high-need patient population with 8.76 injections, and the median time was 17 months. So these are chronic people who had high need over time. What was interesting to note that, all these medicines seem to keep stable vision and stable CST over time. Looking at it a different way, we look at the treatment reduction. Overall, over all the doses, it was a 73% reduction in treatment burden in 12 months. Look at on the left, you got lots of dots and lots of shots. On the right, you have much fewer. And this started as a stage so they could figure out what would be the next stage going forward. This was the DAVIO 2 trial, where they took at a low dose and a high dose, 2 milligram and 3 milligram. They looked at patients who had a history of anti-VEGF injections. They had to have 2 in the last 6 months. They had to show a response because, again, all these TKIs work on the duration play, that they want to extend the efficacy more than try to dry it up all by itself. Vision's 2020 to 2200, they had to have a little bit of fluid, but not too much. Patients were given 2 aflibercept. All 3 doses were given aflibercept at the start, and then at week 8, they were either given a sham injection of aflibercept because they would stay in the aflibercept every other month, or they were given aflibercept with the 1901. Again, supplemental therapy was allowed if you lost 5 letters and gained 75 microns. If you lost 10 letters or gained 100 microns on OCT, or if you had vision-threatening hemorrhage. The primary endpoint was week 52, but it was also being followed up to week 56 because they wanted an average because we had people over time. That was the end of study. The real primary endpoint, I apologize, was week 28 to 32. When we look at this, what we see is regardless of what arm you're in, your vision stays relatively stable and your CST as well. In terms of supplement-free, at month 8, 63% of people in both 1901 arms didn't need rescue therapy, and 87% of aflibercept didn't need rescue therapy. Remember, aflibercept is given every other month. So even with every other month, 13% of people needed rescue therapy. By month 12, you've got around 50% of people not needing rescue therapy in the 1901, while 68% of people didn't need rescue therapy in aflibercept. So that means essentially 32% did. That goes up about 35% needing rescue therapy in the aflibercept arm, and about 43% of people being rescue therapy free, 43 to 45 based on dosing. Looking at this another way, when we look how highly treated these people are on the left. Look how fewer the dots are on the right. It's an 80 to 81% reduction in pretrial treatment, and about somewhere between 43 and 46% injection-free interval at 14 months. Safety, we worry about safety. There were no, EYP 1901 ocular serious adverse events or systemic serious adverse event, no implant migration, no retinal vasculitis, no discontinuation. 97% of them were considered mild or moderate with the expected intravitreal injection. 6 patients with ocular SAEs, none of them were related to 1901. So this led to the new phase 3, which is currently enrolling, of Lugano and Lucia. This is patient with both previously treated and treatment naive. They split the difference and went with a 2.7 milligram EYP 1901 versus aflibercept. Everybody gets 3 aflibercept shots. And at week 8, they also get EYP 1901. Patients are followed over time. What's interesting in this study is there is redosing. So we're going to see how redosing works. In terms of rescue criteria, they simplified it, decrease of 5 letters and increase in 75 microns on OCT. And you can see that the primary endpoint was at week 52 and 56, but it's being followed over time and it's currently enrolling. We're going to move to suprachoroidal injection. This is CLAX. This is a suspension, which is axitinib. Essentially, this is the original OASIS trial with phase 1 and phase 2. These are people who also were previously treated 2 anti-VEGFs in the last 4 months, and they have different doses. What you can see is the higher doses in cohorts 3 and 4 seem to have stable vision and stable OCT, whether or not they were rescued or not. It didn't make a difference. what is interesting to know in terms of the fact that you treat people in this study, what it showed was 100% of people were essentially didn't need additional therapies at month 3, 91% at month 4, and based on the 2 doses, 55 or 73% were rescue-free going forward. This led to the phase 2 Odyssey trial, which is a different trial than the other trials. Yes, people were previously treated. They were given aflibercept. After they were given aflibercept with the CLA, remember, this is a suprachoroidal injection. They got an extra aflibercept shot, both arms, and then patients were followed to see if they need to be redosed. They weren't redosed with aflibercept. They were redosed with the CLS-AX suprachoroidally. And what it wanted to see was what was multiple doses over time. And if they happened not to need a shot at 12, 16, or 20, they got an automatic shot at 24. And the primary endpoint was at 36 weeks. It showed good control of best corrected visual acuity and central subfield thickness in terms of rescue injections, not rescue, but re-injections, 100% rescue free at week 12, 90% rescue free at week 16, 81 at 20, and 67% at week 24. So again, the good news is by doing this, they're able to know what to expect when they do the phase 3 trial, when people get multiple injections like the other 2 clinical trials have seen in the different companies. Again, there's a lot of rescue things we talked about, but this is how they differ. In CLAX, it was 100 microns from baseline. In EYP-1901, it's 100 microns from the lowest CST from two consecutive measurements. And OTX didn't have a CST alone. All of them had 10 letters, okay? But it was whether it was from baseline or best corrected. And then they had 5 letters with 75 microns, but they also had different, whether it was from the baseline or the lowest, depended on the medication. So again, it was similar, but not exact. And when you compare apples and oranges, that's really important. So in summary, we're talking about small molecules, and they really have this pan-VEGF intracellular mechanism of action. Obviously, the different delivery platforms. We definitely see there's a clear proof of concept, and what's really nice is we're able to get things that go away, and you don't need to take people to the operating room, so they're either intravitreal or suprachoroidal. Toxicity does not seem to be a problem. Obviously, the differences preclinically so far haven't really translated into real-life outcomes, and the real-life retreatment intervals are, they differ based on medicine, and they may not be how we would treat in the real world. The other interesting thing is, remember, we reload everybody with anti-VEGF, and really it's a duration play. What'll be interesting to know is that now that we have longer medicines than aflibercept, like 8 milligram or faricimab, we might even get better efficacy and better durability than what we see in our current clinical trials. So that being said, we're going to change gears a little bit, and we're going to have a panel discussion and really talk about cases, because that's what you want to see. And, one of the things you want to figure out is, let's say this medicine gets approved, how is it going to fit into your current therapeutic landscape? So, Carl, why don't you present your first case, and let's see what questions it brings up and see if we can have an understanding and help our audience understand where this fits in their treatment paradigm.
I think that's the $64,000 question. And we all want to know, like, if we had this on our shelf, like, how would we use it? And I'm curious what you think, and I'm going to be curious what happens in the real world when these products get approved. So let's go back and let's talk about one of my patients. She's an 89-year-old female, wet AMD, both eyes, greater than 2 years of disease. Well, it's more than 2 years now, is since December 2020. And she was diagnosed in 2021, actually, with wet AMD in the left eye, 2022 in the right eye. She had dry AMD before then for 2 years. So her treatment history in the right eye has actually been pretty well controlled. The left eye, she was in the daylight trial. That was like KSI 301, tarcocimab versus aflibercept. She got regular aflibercept. She got faricimab. She got high dose aflibercept. And we're going to see how she behaved. In the right eye, diagnosed December 2022, had a little subretinal fluid. Her left eye had already been diagnosed with wet AMD, so I knew what that movie looked like. So I didn't want to let this go. And she did really well. She received aflibercept for, a few times. We switched her to faricimab to see if we get longer durability. She actually started getting some intraretinal fluid and subretinal fluid. Then we put her onto high dose, and she did quite well with excellent vision 2025. Now, her left eye is the more interesting eye in terms of this discussion here. She was diagnosed in October 2021, put into a clinical trial, 2063 with CME. She had a CST of 567. She got out of the trial. with a little better vision, a little better CST, and didn't really look a whole lot better. She then received 8 injections of aflibercept, and the vision kind of stayed around 20/70 at this point, even though it started looking a little bit better. I'm starting to wonder, well, why is she losing some vision? Well, she's starting to develop some foveal atrophy. So for better durability, she had to receive 6 injections of aflibercept monthly. Let's put her on faricimab. Well, she got a little bit worse. She developed a foveal cyst and her vision dropped further. Put her onto high dose aflibercept, and she had an excellent response, but her vision still declined due to that foveal atrophy, but her CST went from 401 to 283, and her vision climbed a little bit to 20/80 after her 3rd injection, remained dry. And the question is, like, well, what do we do now with this patient who's had 3 injections of high dose aflibercept? You know, she had a really good response to it, but my question is, well, why does one patient have a better response to a higher molar dose of anti-VEGF and other patients do better with dual inhibition, like faricimab? Like, why is one agent better than another? And after 3 injections of HD aflibercept, can she really wait 8 weeks for the next dose? And if we don't think so, like, what should we do in between? Like, would a TKI be good for this patient? And you know, we just don't know in these patients in our clinics, like how they're going to respond. You know, some patients are able to extend quite a bit and other patients not. So I think TKIs are beneficial for patients. I think these molecules can be like a backbone therapy where you intermittently inject an anti-VEGF, though we see in some of these trial designs that patients are getting injections every 6 months with a TKI with that durability is there in the trials. Well, how's that going to translate in the real world? And we just don't know yet, but I, for one, am quite optimistic.
So no, I mean, I think you're right. This is a very interesting case, and it's real life. Because I mean, you showed at the last panel, she got 3 shots of aflibercept, and we know label, of course, is every 8 weeks. So the question is, what do you do for this patient, right? Do you see if do you substitute, you alternate aflibercept and faricimab? If will the insurance pay for it? Do you put another aflibercept in the middle? And the question is, can you go 7 weeks and maybe get it done? And what happens? What happens if she or you take vacation? Again, a lot of these things become a real mess, or, obviously wet macular degeneration, they have other concomitant medical problems. These are problems these are tough people. And I'm going to show you someone similar to this to figure out these high need people. Where do they fit? Everybody in the audience has patients like this. And yes, I wish we could figure it out. There have been some studies that talk about whether or not people process VEGF quick and slow. But again, I've not been able, being in, having been in real life studies that as you as Truckee and Tahoe, where we've looked at faricimab in real life, we've seen people that do very well on this, and we see people that go the other way around. And I've got cases that demonstrate exactly the fact that some people need high molar and some people need dual inhibition. But what's interesting I've noticed in my life is when I switch people over, I may be able to get stronger. I typically don't get stronger and longer. Right at that point, I think, have you found that in your thought, Carl?
You know, I've seen, the whole gamut of things here when it comes to switching patients. I try to extend as long as I can. And if I can't, I'll switch to a different, a molecule, whether it's high dose to faricimab or the other way around. And we're a little stuck right now, unless the label gets changed with high dose, where you are, need that 4th dose at about 7 weeks at the earliest. And many patients can get there, but the ones who can't, then we're kind of in a bind. Like, what can we do? Do we do a sample? Do we use faricimab instead? And just some patients, it's a little bit of a roller coaster for them when it comes to their fluid.
And I think
And that's not good for them either.
It's only going to get worse because, you've already mentioned that, the copay assistance programs have run out of money, and, different insurance companies have different rules on what second generation will let they use. So yeah, so having something else down the pike is something for us to look forward to, because if we can have a little bit of breathing room, that would go a long way. So we don't have to worry as much about our patients losing vision, because unlike DME, AMD patients lose vision, it's really hard to get it back. So I'm going to show you a similar case, but a little bit different in terms of I never get this patient dry. So this is a patient who comes in, Here's the fluorescein angiogram. You can see the late leakage. It's a type 1 looking lesion. I start the patient initially on ranibizumab. I give monthly injections. I'm not getting anywhere. As you can see, there's a persistent subretinal fluid. The vision's 20/60. I've given them 35 injections, and it's pretty much monthly. And their vision's gone from 20/40 to 2100 over this time. They developed the cataract, so they get their cataract out. I switch them from 2 milligram to 8 milligram, and it's just like you said, you can give 3 in a row, but then you're kind of stuck. So what do you do then? And I put them in faricimab, and they've done a little better. But the longest I've been able to go with these people are 2 months. And the picture on the right, where it's 20/50 to 20/70, that's the best they ever were. More likely, the picture in the middle is what I end up with, right? Because again, I don't always get them exactly what I want to do. So I've got this persistent subretinal fluid pocket. Now, some people say it doesn't make a difference because, there's been lots of work by Nancy Holcomb and company that there isn't. But the fact that this fluid waxes and wanes and doesn't stay in one place makes me a little bit more worried and the vision, is slightly worse than the best I've ever gotten. Carl, you have patients like this, and how does that play into your thought process?
Right. So I have patients that have variable responses, and some patients actually have a good response, but sometimes that response we see at 2 weeks, and at 4 weeks they reaccumulate fluid, and then we're kind of like, what do we do now? Some of these AMDs are like variants of wet AMD. You might have a patient that has CSR with a neovascular membrane, and we're learning about how these molecules work in those patients too. But I look at this patient that after 50 injections, if they're able to go 2 months and that fluid doesn't change. I mean, if you look at the Tenaya Lucerne trials, a patient that's stable like that would have just been kept on every 8 weeks. It might be acceptable to leave that amount of fluid perhaps, but I'm always worried, like, are we leaving vision on the table? Can we do better? And this may be the case where we need a different mechanism of action.
No, I agree. And I think, we talked about a lot of the rescue criteria of these TKI medications. And obviously, a lot of people would have a hard time of waiting people to lose 10 letters or 5 letters and 75 microns. But in order to standardize it, clinical trials are not clinical practice. And we always find out within the first year how it really performs. Because to your point, Tenaya and Lucerne, we extend people by 4 weeks. I give talks around the country, and literally I was up in New Jersey, and I asked a bunch of people recently, how often with second generation medicines, do you extend? And everybody extends by 2 weeks still, even though we know we should be able to extend by 4 weeks because both of the trials seem to show that. 2 weeks seems to, in real life we don't feel comfortable enough in AMD to extend going forward. That being said, we've shown you our cases. We're going to show you some clinical trial cases from our patients and that were in the clinical trial. So again, you saw our cases. So let's see what the TKI trials look like. So I think we lost the slide there. Let me go back. I don't know if I can go back and show this. So this is a case from the Ocular Therapeutics trial. This was a patient who essentially had lots of shots before. They are one of the frequent flyers. You can see the historical OCT with the patient of 456. And at that baseline, they get their TKI, they get their OTX TKI, and the subretinal fluid you see to the right of the dome has gone away, as well as the fact that now they start to stay flat. So they got their baseline shot, and then the good is this is a pure duration play. You can see them month one, there's small amounts of fluid, but again, remember in the trials here, you had to have 5 letters and 75 microns. So even though you've got fluid accumulating at month 4, the vision is still above baseline. You still got 2-letter improvement. And what's interesting to know in this case, you can see that given month to month, you're going to have fluid fluctuation. So you can see that the fluid can go anywhere from 80 plus 8, growing at 82, 62, 60, it goes down to +9, up to +1 to 32, minus the 0.6, and up to 53. And essentially the vision remains stable. So the reality is that these medicines, I don't think they work linearly. I think, and again, what's interesting, it's an implant. Now, it's supposed to have steady state release, but I don't think everything is as steady state as it looks. But, had the medicine been running out in this case, you'd see loss of vision and increase in fluid, but we don't see that. we're starting to see a little recurrence of the fluid, but the vision has remained stable. Have you seen that in, you've been in lots of clinical trials, Carl. Now I know you're masked in some of them and not masked in others. Have you seen cases like this, or is this a one-off?
No, and some of these longer durability trials or trials for longer durable therapies, particularly in gene therapy, we will see fluctuations of fluid. Even the TKI trials, you may see a little fluid come and go. I've seen patients in a variety of trials that, I always just encourage the patient to stay with it. And then the next month there's less fluid, and we see that here from month 4 to month 5, and we see fluctuation of vision a little bit too. But what this really shows is it's still working. This is a durable therapy, and it gives our patients hope, because a lot of our patients, the thing they fear losing vision, but the second thing they don't want is more injections. They would happily give up a letter for an extra, few months. And here, I mean, these patients, get an injection on day 0, and then month 1 get aflibercept, and then they're looked at for 9 more months, and look at the response here. So I think this gives our patients hope.
That's great. So I'm going to let you take the next case, which is EYP 1901. It's the slide after that. Yeah.
Okay. So this comes from the DAVIO 2 study, and these are patients with frequent anti-VEGF injections that were maintained. And what we see here is that at screening, they already had injections. They had a BCVA of 70 letters, and they look pretty dry. CST, 2017. Day 1, they got an injection. Week 4, week 8, and then we see them, that vision increases a little bit, 74 letters. So it already gained a line of vision at this point by week 12 in someone previously treated. That is maintained week 16, week 20, week 24, 73 letters there, 72 letters at week 32. So this is a really great response of patients who had a couple of injections of aflibercept, the EYP 1901, and then look at that vision maintenance. Look at the CST control. And these are patients that are able to have that maintenance of vision, maintenance of disease control without the injections. And that is what our patients crave.
And I mean, what's amazing, if you look at the most interesting thing to me, as clinicians, we all draw our eyes to the OCT. I think the graph on the bottom is the most telling thing at all, because I'm looking at almost every month before we put them on EYP 1901, they got a shot.
Yeah, this was a frequent flyer, and this is as high need as they come.
Right.
And they got 2 more aflibercept injections, and one dose of EYP 1901, 3 milligrams, and they just took off. I mean, I can just see the smile on this patient.
Yeah, I mean, this is a home run. They're like, really, no shots. This is great. So again, I mean, this is what you want to see. Now we're going to show you different types of things. So we're going to, that's a little bit too fairy tale. I mean, it's great, but you're happy when it happens. But real life, it's a little messier. So I get to do a different case. This is another patient that essentially demonstrates the concept is not to panic, that people, that potentially you're able to still maintain good vision and good OCTs, but there will be fluctuations. I'm going to start at the bottom. I want you to look at the graph on the bottom. This patient got shots every single month going into the trial. So then they go into screening. Now, remember, when we put them in, when we give them screening, they get 2 aflibercept shots, and then they get the combination. This is day 1. You can see the shot. The vision is actually a little bit down, 72 to 65. OCT is 234. They get, they get another aflibercept, and it helps a little more at week 4, and then another one at week 8, and then they get their 1901. There's still residual fluid, by the way, at week 8, and they had already gotten 2 aflibercept shots. Well, actually, they gotten like 14 aflibercept shots, and you can see that now that vision goes up a little bit, goes back up to 72, and the OCT is 213, nice and dry. We watch them, but now just 1901 is on board. There's a little subretinal fluid, so it goes from 72 to 70, and the OCT goes from 213 to 223. Not a whole lot, but the next month there's a little bit, there's a little more fluid, but a little better vision. It's very counterintuitive. And at month 24, we're still thinking the fluid's going up, the vision's going down, but it's really not the vision has been significantly worse, almost 5 letters worse during this patient's journey, and they didn't meet the criteria of this losing 5 letters and 75 micron increase. But next month, it dries up again. It goes from 269 to 242, and the vision got a little better. And then actually the fluid got even better by week 12, but the vision dropped a couple letters. So again, what's interesting is on this case, this waxing and waning, but nobody falls off a cliff. So I think that's one of the things that I always think is interesting, because at least in my hands, when things start to wear off, when we didn't have TKIs, they kept wearing off, right? If I had more fluid and for some reason I didn't have the right medicine, or I couldn't get insurance, or I had to bring the patient back, the trajectory was down in terms of vision, and the fluid was up. This is interesting that even though they're not getting any rescue therapy, they're not losing, the bottom isn't falling out. What's your thought about that?
Yeah, I mean, I think that in the end, we have to keep positivity for our patients. I mean, so from screening to week 32 is a 3-letter difference here. And we're looking at the OCT, and so many times as physicians, we're treating the OCT. And I'm not saying that's always wrong. We have great therapies and a great diagnostic tool that came out around the same time, around 2005, and they're married to each other, and they're great for each other. But in the end, is this patient truly symptomatic? Are they noticing anything? Maybe my patients here in South Florida, who are really specific, they might notice something, with their multifocal lenses. But nevertheless, like, most patients are very happy here. And I think we got to look at how can we maintain good vision, a happy patient, and keep them safe. Because what we don't want is patients start losing vision. But in this situation, patient receives a ton of injections. This patient's very happy with relative maintenance of vision. There is a little fluid. We do have to be careful. If we start seeing it creep up more, then we should probably start acting. But here, this is a happy patient, a good response.
Sounds good. I'll let you take the next case.
Okay, so here is a patient from the high dose cohort, and those who remained without supplemental injection for 12 months after a single EYP 1901 treatment here. So here's a patient who had multiple injections before entering the trial, and then at month 0 received 1 injection of 1901. So at baseline, 85 letters, CST 232, got an injection there. And then we look at the vision, month 1, 85, 283, and that is maintained. Even month 6, 84 letters is a 1-letter difference. Month 9, 81 letters. There's a little, some fluid, maybe some Schrem appearing underneath the fovea. The CST's bumped up. It's increased 32 microns from baseline. Vision's down 4 letters. Let's watch it. Actually gets a little bit better by month 10. Vision then drops a little bit to 79 letters. So now that's a 6-letter difference from baseline. But at month 12, they dropped a little bit more, and that's where they get re-injected. But nevertheless, this is a patient that went essentially 11 months without treatment. What happened after month 12, we don't know at this point. That's not released, but the vast majority of these patients are able to regain that vision that was initially lost. These patients were followed monthly, and therefore we were able to catch it quickly.
Absolutely. And, the reason this patient, again, the fact that there was, the OCT, I think, brought it over the edge for criteria for retreatment, as well as the vision. I mean, you get 12 months. I mean, we don't know many medicines right now that you give a shot and 12 months later, they're fine. I mean, that's pretty amazing. So again, it's definitely something that the potential for these people in certain people, for this medicine in certain people is unbelievable, because of the fact that you really cut their treatment burden, almost eliminate it. But we're not sure who it is. And obviously, as we get better understanding, I think we'll be able to stratify our patients better and say like who will be the winners. But I think it's going to take a lot of work. But again, having something else in our armamentarium that we can sleep at night, especially because again, when these people miss appointments and things like that, you'd like to know you've got something on board that sticks around longer. This is another case that I'm going to talk about. This is from W2. It's a case study with frequent injections that maintain for 6 months. Okay, this is over time. We don't have this long follow-up, but again, this is a patient who comes in, they get their 3A aflibercept. Like look at the graph at the bottom. Monthly injections. Every month they were getting an anti-VEGF injection. On screening it's 70 and 217. On day one, it's 70 and 236. After the first shot, you got a little better vision, a little drier OCT. You give the third shot, essentially, you're pretty much as good as you're going to get right now from that. And then you actually get one letter improvement from the third shot. The OCTs within 3 microns. I mean, we're talking about small amounts. And then it kind of stays. You stay 74, 73. The OCT stays. This is another one of those cases that are really a one and done. That really, though we only have 6 months of follow-up on these people, it really portends a really good prognosis. So again, what's really nice, the vision, although the vision doesn't jump up, it doesn't go anywhere, and the OCT remains dry. So I think, again, as you said, Carl, this is probably someone who would have a big smile on their face and say, look, this is okay. Because I've never met a patient who was actually, I had one patient in all my years who was upset when they didn't get a shot, but everybody else is like, they're thrilled. Happy to see, I'll see you and not get a shot every day of the week, Dr. Singer. So that's pretty happy. So if we can get that burden down, we'll go from there. Do you have anything to add?
Yeah, the one thing I'd add that's consistent across these different trials, and we see in the cases too, is safety. I mean, not only does it seem to be a durable treatment option, hopefully treatment option, it's a safe one, and our patients are not, we're not seeing serious adverse events here. We had that one case of endophthalmitis in the clinical trial, but that was done after the aflibercept injection. So that's what we do in the clinic anyway. We're not seeing IOI or vasculitis in these trials, and that's very comforting.
And the other thing you're not seeing is you're not seeing hypotony. There's a lot of hesitation. You're putting a 25 gauge needle in people. People worry about having issues with that. You don't have those hemorrhages. I mean, I think overall, we really have pretty good experience with larger gauge needles. There's the Ozurdex and the Illuvian. They're well tolerated. We know how to put implants in people's eyes. It's not something we haven't done before. And of course, the suprachoroidal injections are currently being used for Xipere, which is triamcinolone for uveitic macular edema. So again, you're not learning a new skill set, which is wonderful. So again, when these things get adopted, you don't have to retrain. Plus, one of the things we worry about with other therapies are inflammation, and inflammation really isn't an issue here. And none of these cases have the things we really lose sleep on, vasculitis and occlusive vasculitis or retinitis. So again, what's nice about this class of drug, like you said, it really is something that helps you sleep at night because they haven't seen something so far that really, worries us. That being said, let's see, we're going to talk about, these are open-ended questions before you get questions from the audience. So once these things get approved, what's going to guide your choice of going anti-VEGF versus TKI?
So if we have TKIs plus what we have on the market now, what I want to learn is how do they interact with each other? We see in the trials aflibercept supplemental injections. I want to know, well, how does faricimab interact with this? But when we talk to patients, I say, like, look, the molecules we have target specific aspects of those ligands of the VEGF receptors on the surface, the extracellular space. But this TKI works in a way to target multiple targets inside the cell to help create better stability of your disease. And I think that's how we can kind of counsel patients. It's hard to say right now what's going to guide the choice, but maybe someone who lives a few hours away, we have many doctors in this nation where they're the only option for patients that may be a few hours from them. I had a good conversation with my friend, Dr. Kanani, just the other day. about someone who called my practice in Florida who moved to an area of Nevada 2.5 hours away from Reno, and there's not a retina specialist. Reno is the closest city, and the next closest one is Salt Lake City. So that's 2.5, 3 hours away. So maybe a TKI would be great in a patient like that if she were to develop wet AMD. Um, but then we got to think about how do they fit in our practice? Where are they going to, is there going to be a step therapy? We just don't know. But I think in the end, I mean, this is going to be a potential game changer for many of our patients, especially the ones that loathe frequent visits.
Sounds good. So we'll take a couple of questions. One of the questions I got from the audience was during one of the cases wanted to know about potentially autofluorescence. In general, a number of, at least in my practice, we have a couple of main clinics and then we have satellites, and not all of the satellites have autofluorescence. But I think the question really gets a little bit more, if we want to go a little bit more broad, where does autofluorescence actually play into your treatment algorithm? Because one of the things we have, as we all know, is if you give enough anti-VEGF injections, you have to worry about macular atrophy. In your treatment paradigm, when do you start thinking about that, and what do you use as a biomarker for that to say, maybe there's atrophy, maybe I should use an autofluorescence?
So in my patients, they get an OCT at every visit, period. I will commonly add an autofluorescent photo every 6 months. And I will look at the OCT and I'll scroll through. I actually note in my chart if a patient has iRORA, because sometimes an autofluorescent photo will show you what appears atrophy, and you look at the OCT and it's not true CRORA, not complete atrophy. So the autofluorescent photo will help guide that. But if someone has atrophy in the fovea or in the FAZ, like you might not be able to image that so readily with autofluorescent photos, and you have to use your OCT, which I think is going to be the guiding diagnostic modality moving forward.
So for us, I mean, I look at my OCT, I also look at the infrared image. And I take the infrared image to say, look, because again, sometimes I'm looking at this and wondering to myself, why is the patient's vision they say, it's the same and my OCT is dry, but they say they see worse. That also will prompt me to get a autofluorescence image in addition to the iRORA and CRORA, because again, some of our scans are serious and they're not optimized just for retina. It gives you an opportunity to help explain to the patient what's going on. And given the fact that in 2025, a lot of companies are now on TV talking about both wet AMD and geographic atrophy for their therapies, it's easier to explain to the patient about what's going on because they at least have some familiarity. So one of the other questions that came us, what do you think that the greatest unmet need that TKIs will fill? Do you think it's going to be wet AMD, or do you think it's going to be DME?
I still think it's probably going to be wet AMD at this point. We have some really good therapies for DME. We need better therapies. Some of the steroid therapies for DME work very well, but there's some side effect concerns where there's cataract progression or IOP control or IOP issues. So we have good therapies in the DME. This may help in that regard, but if we can really help our wet AMD patients who are a little bit older, and then if you have these wet AMD patients that also are being treated for GA, this may help because you would be able to maybe treat them more readily for GA as opposed to the alternating therapy with, an anti-VEGF too.
No, that makes a lot of sense. And obviously, I asked you the question instead of me answering it because you know my feeling about steroids. So that being said, I also agree to your point that we don't have as many options available for wet AMD. And one of the interesting things there are subsets of wet AMD that are pretty recalcitrant. Obviously things like pachychoroid. Pachychoroid, although not very prevalent in my neck of the world, if you basically are in, on the West Coast or in Hawaii or in places where you might see it. And I think it's actually more prevalent than we all give it credit. Greg Gakami spent a lot of time saying, hey, look, it's not just Hawaii, it's in lots of places. Those lesions are very recalcitrant to anti-VEGFs. Yes, they look like they're going to look a little better. I mean, I did some work showing the dose for high dose in this patient population. But again, it's always monitoring and you're always still chipping at it. So I think that will be one of those things where I think sustained high VEGF load may really hit the trick. And to your point before is that we've got other things for DME and RVO for that matter. AMD is pretty much the lonesome where we really, yes, we have faricimab, which is great, but we don't really have other things that are really extended duration therapies. So I think that really has some real value. I see we are pretty much at the top of the hour, so I want to thank you, Dr. Danzig, for your time. I want you to look, and I want, in order to thank you all for attending, we really appreciate it. There's a QR code that we want you to scan, so you get it. You'll get your email on how you get your CME credit. I want to thank the audience for their questions and for sticking around. Hopefully, you gained some insight on what's coming down the pike in terms of tyrosine kinase inhibitors, and listening to us hopefully gave you some insight on how maybe you'll incorporate it into your own treatment algorithm. Carl, thanks again for being with me, and thank you.